Actually, he asked us whether we can start on time. So, is this possible for you there?
We now are ready also to start. Over here are also our speakers who will today present our cases for radiation therapy of lung cancer. Tatiana Shirabura, you already know her. She came for your annual cancer conference. And over here also is our deputy director for radiation and chemotherapy, Nikita Volkov. So they both will be glad to share with you our experience in this direction, as well as the radiotherapist from our also department, Polina Brukhanova. Okay.
So thank you. So today we have Dr. Min, who is just came back from Russian. So we can have the translator of Russians here today. But I hope that our speaker will make the presentation in English so that you can hear us. But whenever you present in Russians or in English, English is okay for us, but Russians there, we have a translator to the, here. So thank you. So,
we are really glad to have this opportunity. Yeah. Our doctors can also, of course, present in English, but if there will be any misunderstanding, then we will ask for the help. Thank you very much for this opportunity.
So shall we start now with your presentation of our presentation?
Yes. Okay, you can start, please. Share your experience.
Thank you. So please, Dr. Ting.
Hello. Good afternoon, ladies and gentlemen. Today, Dr. Ting, I'm very honored to present the current status of radiation therapy of non-small cell lung cancer in our hospital. According to Global Count 2020, lung cancer is the second most cancer in our country. And from a statistic of the 5 biggest cancer hospitals, as you can see, up to 80% of patient was diagnosed with the stage 3 or stage 4 for the first time. We have a full range of diagnostic tools such as imaging, procedure, and molecular biology. Unfortunately, we don't have a mediastinoscopy, EBUS, CT-guided biopsy. It is circumvented. If necessary, we have to transfer this patient to another hospital to do it. Currently, we have 2 facilities with 3 simulators and 13 radiation machines. Now, I would like to tell you some characteristics of the radiation therapy in non-small cell lung cancer. Regarding the characteristic of inoperable stage 3 non-small cell lung cancer in our hospital, as you can see, majority of patients have a very high volume tumors in lymph node tumor, as you can see the images. And especially the tumor and the lymph nodes are very close to the organ areas at the spinal cord or the esophagus that lead to a very difficult in treatment planning, and obviously it's had an unfavorable outcome. Before 2019, we didn't have a multidisciplinary team. The statistical lines was not adequate, lack of capacity, and we had only used the 3D conformal radiation therapy. So a very few patients can treat it with the concomitant chemoradiation therapy. After that, we have many changes in diagnosis and treatment. Two turbine machine and breathing control system were equipped, so more and more patients can benefit from the concomitant regimen. About the regimens, we only use the dose 60 gray in 30 fraction. We don't let you use 56 gray and 33 fraction because I'm afraid of the side effect, especially radiation-induced esophagitis. About the chemotherapy, we only use the weekly regimen, palitasa and carboplatin. Durvalumab consolidation is indicated for this patient who can afford it because it's not covered by the medical insurance. Besides, sequential chemo radiation therapy is indicated in some circumstances, such as the patients with very huge volume that doesn't satisfy the dose control for the first time, or this patient have a prior chemotherapy in another hospital. And the last one, this patient with poor performance that cannot tolerate the concomitant regimen. This is the outcome in our country. From a statistic from some hospitals in our country, as you can see, the numbers of patients treated with concomitant chemoradiation therapy were not too much. And all of them were treated with the 3D conformal techniques. And the 3-year overall survival was only around 36 or 39%. I would like to talk to you about differences of indication adjuvant radiation therapy in our hospital. According to ASTRO and ESMO guideline, there is no grounds of adjuvant radiation therapy in patients with PN2 error 0 resection. However, due to unequal surgery quality amongst hospitals in our city, we have to reassess the surgery quality, especially the systemic intraoperative lymph node assessment. And the more high-risk fractures this patient have, the more ability we can maybe consider adjuvant radiation therapy, as you can see here. We move on to the radiation technique. When this patient is treated with 2 beam machines, the simulation were performed with 4D CTs and RPM system of variance for respiratory motion management. And in this way, the range of the tumor motion can be visualized in 10 phase CTs. Delineation is based on some international guidelines. In our hospital, with non-small cell lung cancer radiation therapy, we primarily use the technique RMRT and VMAX because this patient has very huge BTV. Although the number of patients waiting radiation therapy in our hospital is always overcrowded, this patient with lung cancer have some priorities due to the rapid progression. We have to try my best to shorten the interval time from diagnosis to simulation is not over 1 month, and from simulation to the treatment is not over 2 weeks. When treatment delivery, this compensated guidance will require the average 8 sessions, and the radiation beam is activated by phase gating. Adaptive radiation therapies can be used in some special circumstances, such as the tumor causes collapse lung, or the tumors have a very excellent response. This case of collapse lung due to the central tumor. As you can see, after the 3 week treatment, the tumor had a very excellent response, and the simulation and treatment plan was done again. We also have international collaborations in the field of high-tech radiation therapy guidelines and protocol process. And for the lung metastasis, SPRT, we developed it in 2019, and until now we have only 3 cases treated with 48 grade in 4 fractions. In summary, we have to talk about some advantages and limitations in our department. About the advantages, our diagnostic tool and radiation therapy facility, as you can see, are well equipped, and the multidisciplinary will take place every 3 weeks. Fortunately, we have some opportunity to take part in some of the international control trials at the Pacific trial. Besides, we have also some limitation. As you know, majority of patients was diagnosed for the first time with a very high tumor volumes, and that leads to unfavorable outcome. And currently, in our department, only 2 cases in small cell lung cancer per month can satisfy concomitant chemoradiation therapy. High medical expense is also an issue because the medical insurance doesn't cover 100%, especially for the high-tech radiation therapy. And the last, heterogeneous quality of our hospital in the city is also influence the treatment outcome. Thanks for your listening.
Thank you for your information. It was very interesting. I think that we'll now introduce our information, and then I think we will discuss this problem. Let's start. Dear colleagues, we would like today to discuss the problem of toxicity of radiotherapy. The toxicity of toxicity of radiotherapy and chemoradiotherapy of locally advanced lung cancer. Lung cancer is one of the most common in Russia, and in 2021, nearly 1/3 of patients with newly diagnosed lung cancer have locally advanced stages, but chemoirradiation received only 3%, and toxicity is one of the reasons. We use radiotherapy at all stages. We also have the experience of stereotactic body radiation of early stages of lung cancer as alternative to surgery, and also radiotherapy for disseminated disease with palliative intent. But today we would like to discuss the problems of chemoirradiation of locally advanced cancer, lung cancer. Chemoirradiation is the main variant of treatment of locally advanced cancer, and according to American College of Radiology, patients with clinically evidence of mediastinal lymph node metastases are the main candidates for chemoirradiation. Chemotherapy and irradiation can be delivered sequential according to poor status or large volume of radiation, but concurrent chemoirradiation is the preferred option. The treatment, scheme of treatment is the same. You patients receive conventionally fractionated radiotherapy with the dose 60 gray in 30 fractions, with chemotherapy and mainly paclitaxel with carboplatin weekly, and then finished without progression, receive consolidation immunotherapy. Radiotherapy planning and simulation include immobilization. We use Winbot only, 4D CT, fusion with pre-treatment PET-CT for irradiation, for involved field irradiation, to reduce the volume, irradiated volume. We use different forms of breath control, respiratory gating or breath hold technique. We use technologies include IMRT, IGRT, just as you, and the volume of irradiation is just the same. Radiotherapy and chemoradiotherapy are associated with different toxic events: acute, usually hematological toxicity, and radiation esophagitis, and late toxicity, the most severe pulmonary and heart toxicities. Toxicity is associated with volume of radiation and the volume of, and the dose to the certain volume of organ at risk. We use international normal tissue dose volume constraints for conventionally fractionated radiotherapy with concurrent chemoradiation, and also the constraints from different materials, the constraints that are associated with the increased risk of death. Here the constraints for esophagitis, clinically significant esophagitis, but I must say that sometimes it is difficult to avoid severe esophagitis, especially when the esophagus is near or just inside the irradiated volume, target volume. Pulmonary toxicity is the most serious, I must say, and the risk of pulmonitis increase with the increase of mean lung dose. But the main constraints, the volume of lung received 20 grays, and for IMRT 5 grays. Those volume constraints are based on precise delineation of organs at risk, but sometimes there are some specialists have their own opinion about the volume of lung. Our colleagues from China and USA think that excluding PTV from lung volume may better predict radiation pneumonitis for IMRT of lung cancer. But we use we exclude only GTV from this volume. There are also another factors, chemotherapy, the variant of chemotherapy and patient's age are associated with more severe pneumonitis. Previously, it was confirmed that modern technologies with a modulated intensity provide more protection of organs at risk than 3D CT. But even today, it's no consensus among specialists about the what is better, dynamic or dynamic arc therapy or static beam radiotherapy. Specialists, radiotherapists from Japan believe that dynamic versus static beam radiotherapy provide better target coverage, low dose to spinal cord, but increase the low dose to lung area. What about is about heart toxicity? It is important for a long survival. Here the constraints for heart toxicity. Modern technologies provide more accurate dose delivery. So, as dose to heart toxicity and lung toxicity, the main affects the overall survival. So we try to reduce the dose to the heart and to the lung as low as possible. And now we will introduce you our experience of chemo irradiation of locally advanced lung cancer and the planning of IMRT technologies. Paulina will start.
Dear colleagues, nice to see you all again. Here we can see some clinical cases from our center. Let's start. First clinical cases, it's a male smoker, 66 years old, with locally advanced squamous cell lung cancer of upper lobar bronchus. As you can see, he had PD-L1 negative status, and MDT prescribed for him on the radiation therapy because he had contraindications for chemotherapy, for concurrent chemoradiation therapy. And he received 60 grays in 30 fractions. Here you can see dose distribution for this patient and our clinical goals for organ at risk and targets. At the table, you can see two types of prioritize, P1 and P2. P1, it's doses from international recommendations like NCCN or RTOG, and P2, it's our center recommendations that we follow for most of patients. Our clinical goals we formulate for our patients because now we have more treatment options for patients with lung cancer, and it's a longer overall survival of this patient. Because of it, we follow our criteria with low doses for some organs at risk. Let's discuss some organs at risk of these patients. For example, mean dose to heart less than 20 gray. It's an international recommendation. We have 30 grays. Volume that received 50 grays for hearts. In recommendation, we have 25%, and our doses is 5% only. We have low doses for heart, for example, volume of hearts that received 5 grays. In recommendation, in some trials, we have 30% for this. But in this case, we have 48% because of upper left localization for this patient, and this low dose we can't follow our criteria. And left lung, let's discuss. In NCCN should as follow the criteria V20 less than 40%, and we have 36% for this patient, and mean dose less than 15 grays. It's very, very low criteria. After 3 months of follow-up, patients did CT scans, and it was partial response, as you can see in the slide.
No.
Yeah, good. Next case, it's a male 2, smoker, 67 years old, stage 3B of squamous cell carcinoma, PDL status -2. He received chemoradiation, radiation therapy in MRT technique and in the same regimen, 60 grays, and chemotherapy TC for 4 cycles. Here you can see isodose for this case. In the table, it's the same parameters of P1 and P2 as we discussed earlier. And for this case, let's discuss doses for spinal cord. In recommendation, we have a max dose less than 50 grays in standard recommendation. In our center, we use criteria dose max less than 35 grays, and we follow these criteria for all patients. And about heart, here we have mean dose for heart less than 3 grays. We observe this patient every 3 months, and at the first follow-up, we can see total response and total local control, but distant dissemination of this patient, it's metastasis to bones and liver. And the last case, it's male, 75 years old with stage 3C and PDL positive status. He received concurrent chemoradiation at the same scheme as we discussed earlier. This patient had very large tumor in the left lung. It was hard to follow all our criteria. Here we at first think about pulmonary toxicity and follow lung criteria at first. For example, volume that received 20 grays, here is less than 39%. It's like an international criteria. We follow this. And mean dose for lung was 23 grays. It's okay for this volume of tumors. Mean dose to heart was 7 grays. It's a low dose too because of left localization. And 5 gray dose to heart volume was less than 26%. Here we have esophagus in our planning volume, and let's see some dose to this organ at risk. In recommendation, we have mean dose less than 34 grays, and we follow this criteria too. After 3 months of follow-up, this patient did PET-CT scans and have partial response, good partial response. In conclusion, I would like to underline that we follow all RTOG or NCCN criteria for all our patients, but our goal is minimize toxicity, pulmonary and heart for this patient because of their longer overall survival today, and because of it, we use our own criteria of our center, minimize some dose for organ at risk. And all our patients from these cases complete the treatment without toxicity more than grade 2 or 3 for all organ at risk. And all patients were candidates for immunotherapy durvalumab, and now they continue maintains durvalumab therapy. Thank you for your attention.
Okay, so this is our presentation with the cases also, which we would like to show you. Now, I think we can discuss the our experience, both of our countries' experience in this topic.
Xin mời anh Trung. Anh cứ nói tiếng Việt cũng được, rồi cái gì mình sẽ chuyển sang tiếng Nga cho. Có hỏi gì về họ, về cái cách làm của họ cũng như là cái vấn đề của mình không?
Hello.
We can hear you.
Yes, thanks for your nice presentation. I would like to ask you about some question about the side effect during the concomitant radiation therapy. In your department, what is the most side effect you meet? And especially for this patient with a very big TTV as a clinical case 3.
We avoid severe toxicity in all cases. The esophagitis in last patient was not severe, the grade 2. We don't have the problem with esophagitis as we deliver patients medication, necessary medication and supportive care during the treatment. I think that the main problem is the precise visualization and the radiation of involved lymph nodes and tumor and the precise delivery. And we see that it allows us to avoid severe toxicity during the treatment and just after the treatment, chemo radiation, and patients then can receive immunotherapy. I think that it will be interesting to change the plans of radiotherapy of lung cancer if it will be interesting for you. We can see your plans and you can show us your plans and we can introduce you our plans if it is interesting for you. It will be very interesting for us to see your plans, dosimetric plans of chemo radiation of lung cancer. If you have, or maybe you have no problems, but we are looking for different variants of planning to reduce the dose to organs at risk, as small as it is possible.
Did you catch the idea of Dr. Sharabura?
Maybe not.
Okay, so what do you think regarding this?
Or maybe you will discuss it among you and then we'll communicate again.
Да. Стесните мне планчики.
Да, нет, или они не поняли, или это...
Может, они вас не слушают?
Да нет, не слышат. Эти они сейчас между собой еще пообсуждают.
Мне кажется, они не очень поняли. По-русски да, могу сказать.
Седовласый мужчина справа уже истеребился в свою кофточку бедный. Изнервничался.
Нет, он, по-моему, смеется.
Dr. Khan, can you hear us? Did you catch the idea of Dr. Sharabura? I'm sorry.
Yes. Yes.
I can.
Yeah, we can hear you very clearly. So we are discussing about how to change the information and also the planning course to compare between us and your institution. We are discussing here.
Okay.
Yeah,
Perfect.
we looking forward to cooperate like Dr. Salabura already suggest us to do. Well, we are asking whether our system could receive the information and then analyze and blending, drawing contour and blending or not. Yeah.
Okay, then we can do it whether, if you like it, on the next, some of the next video conferences. You just can show us during the discussion these plans, and then we will discuss, show you also our plans as well.
I would like to add, if you have any problem, we can show you our plans. We can show you our plans during our discussion. But I have seen that rectal cancer is most common in your country, and if you want, we next time we can discuss this problem, the radiation of rectal cancer and anal cancer.
Yes. So we agree that the next topic is the rectal and also anal cancer, because we have so many cases here. But
yes, I see.
Yeah, but the idea is we exchange the case, and after that we will see the technique of the blending for radiation to see whether this is good or not compared your institution and also our hospital here. Is a good idea, but the way we change, we exchange the case and the information, the imaging is, I think that a little bit difficult to for us to have the image to make the contour. And how about your opinion, Dr. Salabura?
Yes, I must say that we have a very experienced medical physician, and we can invite him next time. And if you have any question about lung planning, the planning of irradiation of blood cancer or rectal cancer or anal cancer, he will answer your questions. Okay?
Yes, and we also ask our physician attending the meeting as well.
Perfect.
Yes.
Thank you.
Thank you.
Very much. В конце этих случаев у вас есть какие-то вопросы?
No, нет.
Okay, Dr. Khan, then I would like also to ask you regarding the plan which I have sent you recently about our future cooperation. The thing which we would like to know whether you would like to also plan some events with short or long-term fellowship of the doctors, both on the base of our center as well as in the Ho Chi Minh City.
We have our Vice Director, Dr. Waktan, also joining now, so he will give some ideas on about our long-term cooperation of exchange, the fellowship with fellow doctors. So.
Hello, Anastasia, and hello, everyone. Hello.
Nice to see you.
Because, and in terms of the collaboration between the two settings, your institution and my own hospital in the future, I think that there are 2 points, and we continue to the video conference, something like this. And I suggest, and in the future, for example, in radiation therapy, and 1 week before between the meeting, and probably we share the clinical case, and both sides, you and our staff, we do contouring and planning everything, and then at the meeting we will share each other, and we share point of view of each other, the reason why you do something like this, the reason why our staff we do something like this, and what is the difference. And so I think that the first thing I would like to share with you. And the second one is in terms of the visit of your doctors to my hospital and doctors from my hospital to your hospital. And I agree. And we should do. Because, you know, now we move to the new location, new facility, bigger than this one. And so we are more than happy. Welcome your doctors to visit my hospital, my new hospital in the future. And we are also very happy to send our doctors to visit your center as we've done in 3 years ago, probably 2 or 3 years ago. And Dr. Tan and Dr. Khoi visited your oncocenter. And so we continue to this program. So because we can share each other our experiences, not only in there are many field, radiation and medical oncology and surgery as well. And the third point, and we continue to invite your doctors to attend our annual conference on cancer in December, annually in December. So we are very happy to have your doctors to join the meeting like we have done last year and before last year. And so I agree to do something like this. And I'm not sure, but you know, and if possible, and if as your setting, your hospital, you have any clinical research or clinical trials, and if so, we can work together. We can work together if you have. And so like now we are working together with Japanese NCC, National Cancer Center in Japan, to do some clinical trials. For example, to collect rare cancers and how to treat them. And so we can learn each other via clinical research or clinical trials. That's all. And so I think in our next plan, and we can continue to do something like this. Have you any idea, Anastasia and Dr. Sarapova, and on your staff there?
Thank you very much for your comments. That's, of course, a great idea. Regarding the video conferences, we will send you the data for our patients 1 week before. That's no problem. So all of the doctors can see the materials before the conference and plan everything. That's fine. Regarding the fellowship, then we propose to share the candidates for the fellowship. So you can see whether our doctors can be, convenient and suitable for the fellowship in your center. And you also can send us the CVs of your doctors which would like to come to our center. And we will also discuss the program of the fellowship on the base of our hospital as well. I also would like to mention that we will also be glad to see not only the doctors, but also the medical sisters, the nurses, of your hospital in our center as well, if they speak English. So this is no problem also for us to welcome your nurses on our departments. We also have this experience with our other hospitals, so that can be interesting as well. Regarding your annual conference, I think we will be more than glad to take part in this conference as well. Just when you will be forming the program, we will send you our proposals regarding the presentations from our doctors, so you can tell us whether it is convenient for this topic or not. And the last thing regarding the clinical cases or clinical trials, I will give a word to our Deputy Director, Nikita Volkov. He will tell you his thoughts about this, because I'm not in this process and I can't say anything regarding that. Thank you.
Hello. So if I understood you right, you mean observational studies. So we are trying to analyze the patterns of care for example, patients with breast cancer, with stomach cancer, and with lung cancer, and others. And we analyze real life efficacy of modern drug therapies and so on. And we think that the combining our data, mainly retrospective data, and analyzing what are the differences in the patterns of care, and how results differ or not differing. So it is very interesting, and we are open for collaboration in this field. In our center, I think prospective trials is quite difficult to organize because of regulations. So our clinical research is mainly focused on retrospective studies. And so we are open for your proposals, and we will think on which areas in our in patients' care we could propose to investigate in collaboration.
Okay, that's great. And so in the future, if you think we can get involved in the clinical trial done at your institution, feel free to share with us, and we analyze the protocol, everything. And if we think we can work together with you in this area, we are very happy. And as you mentioned, and probably this is observational research or something not very complicated, but I think that is the first step to consolidate the collaboration between your center and my hospital. Now I'm coming back to the second point regarding the fellowship exchange, and there are 2 points. And the first thing, we will identify, and probably we will continue to contact via email to identify the date, appropriate date for you and for our staff. And we should think about this. And the second point is I think we should work together with Polisan pharmaceutical company.
Yes.
Yeah.
Yes.
Absolutely.
Yes. That's no problem. We have. Yeah. I'm sorry for interrupting you. I just had the discussion with Polisan. Yes.
Yeah. They will support our doctors to visit each other in the future. Okay.
Okay. Yes, of course, it's not a problem.
Okay,
so you can choose the doctors and the nurses, for example, you would like to send to us, and then we will discuss it with Polisan. I hope they will be as welcoming as last year, and they will help us with the financing of this aspect.
But by the way, I'm curious. I'm not sure Polisan is willing to support nurses to visit.
I will ask them. We hadn't got this dialogue before, but I hope they will be looking good on this idea as well.
In my experiences in Vietnam, the pharmaceutical company and they support many doctors. They are very rare. They support nurses to study abroad or something like fellowship exchange. So, and we work together with Polisan, and if Polisan is very happy to support our nursing to visit your center, I think that is very good news for our nurse, because they can have a good opportunity to work together with Russian, and nurses in cancer field. It's great.
I mean, nurses are the ones who actually use their Polisan medicine. So I hope they will be interested in that experience as well. So
Yeah, sure. Sure.
let us discuss it, but I hope they will be fine on this.
Yeah. Okay. Understand.
Thank you very much for the discussion. We are really glad to see you after the long holidays, and we do hope we will proceed our cooperation this year in this kind of effective temp. And so we will just exchange our ideas via email soon. So I will write you back with our proposals regarding all the topics we now discussed, and then I hope we will proceed with our plans for the next few months.
Okay.
Thank you very much.
Thank you. Большое спасибо. До свидания.
Thank you. Bye bye.
Thank you.
One more thing, Dr. One more thing, Miss Anastasia, I will create multi-channels contacts. So via email, I think that I will create one group of possible WhatsApp or Viber to help us, because I myself here and we have a Dr. Min, and I will ask one other doctor to who joining our group of chatting, so that we can have a fast contact channels, and then we will create a private another email just for your contact, in order to keep up with you on time. Okay.
That's fine. Thank you very much. Yes.
So could you please help us to share to add one or more panel from person from your institution?
Of course.
To share the responsibility in contacting between the two hospital and institution. Okay.
Of course. Yes, of course.
Thank you, Mr. Anastasia. Thank you.
Thank you very much. Thank you. Have a good day. Bye bye.
Вам всего хорошего.
Recording stopped.